Hello everyone, I'm Dr. Ahmed D. Abdulwahab and this is Highlights in Radiology. Hi, before we start, I just want to remind everyone to subscribe and share and support us please and tell us what you think we should do in the coming episodes. First of all, I chose a very unusual topic for today's highlights in radiology. I will not take much of your time, maybe 5 or 10 minutes. So please stay with me in order to know what are the possible causes of a lucent lesion of the calcaneus. We know that the calcaneus is the largest bone of the tarsal bones, and sometimes we come into x-rays that has a lucent lesion involving the calcaneus bone. So what is the possible differential diagnosis in this condition? We will divide them into two groups first, the common and the uncommon. So let's start with the common group. The first and the simplest and the most common lucent bony lesion of the calcaneus is a simple bone cyst, simple unicameral bone cyst. And for example, you can see here, in this condition, there is a well-defined, very well corticated lucent lesion seen involving the calcaneus. It has a narrow zone of transition. It has no specific calcific pattern of the matrix, and it has no destructive effect, and it's very well consistent with a simple bone cyst or unicameral bone cyst. Another example we can see here on the CT scan, you can see it has a very well defined thin cortex, non-expansile, non-destructive, no soft tissue component, no signs of extension to the surrounding tissue, no pathologic fracture. So all of these are features of a simple bone cyst, and on MRI it has all the characteristics of any cyst anywhere in the body. It's well defined, it's hyperintense on T2 weighted fat saturated images, it has clear surrounding bone marrow, there's no surrounding bone marrow edema, the surrounding cortex is intact, and it's simply consistent with a simple bone cyst. The other common possible differential diagnosis is lipoma. On an X-ray, lipoma will be very hard to differentiate from a simple bone cyst, possibly easier on a CT scan by measuring of the density, because the lipoma will have a lower density than a simple cyst of the bone, and on an MRI it will be the easiest to have all the criteria of fat within it. So let's see, for example, this X-ray, this lesion, it's a very well defined, lucent. Most likely we will report it as a simple bone cyst, possibly even two bone cysts adjacent to each other, like this one and this one. However, when we do a CT scan, we can see that this lesion has a fat signal intensity. We just measure the Hounsfield unit, and if the Hounsfield unit is within minus, for example, 40 to 60 Hounsfield unit, then this is fat, and it indicates a lipoma, which is benign in nature. It has no any significant pathological consequences. And if we do an MRI, like in this case, with a well-defined lucent lesion in the calcaneus on an X-ray, we can see that this lesion has a hyperintense signal intensity on T1 weighted images, and on fat saturated images it loses all signal intensity, like in this condition, confirming that it's hyper intense with loss of signal on fat saturated images. These are all in favor of a lipoma. The other possible differential diagnosis of the common group is osteomyelitis, which is the same findings of osteomyelitis anywhere in the body. So osteomyelitis will manifest as an ill-defined lucent lesion. This is a CT scan, of course. ill-defined lucent lesion with possible cortical destruction, and if you notice carefully, there is an extension into the adjacent soft tissues with even possible sinus tract formation into the adjacent skin. Let's see another example. On an MRI, you can see the difference from a lipoma or a simple bone cyst. First of all, there is mild edema of the surrounding bone marrow. All this bone is inflamed and edematous, and if you can see, this is the abscess, let's say, destroying the bony cortex, and even the surrounding soft tissues are all inflamed and edematous, and there is a little bit of sequestrum here, confirming that this is an osteomyelitis of the calcaneus. Another example, on a CT scan, you can see it's ill-defined because it's an infection of the bone. The cortex is destroyed. You can see the adjacent soft tissues are all inflamed and edematous with easily seen sinus tract formation into the adjacent skin, confirming this is an osteomyelitis. The other common possible differential diagnosis is what we call a pseudocyst. That is, when you do an MRI, when you do a CT scan, nothing, there is normal, it's normal, just seen on X-ray, and it's due to a normal thinning of the trabeculae. The trabeculae are thin, and in fact, in my opinion, this is probably the most common cause of a lucent lesion of the bone. For example, you can see here, this looks like a lucent lesion of the bone here. However, there is the trabeculae are just thinned. If you can look carefully, it is crossing the lesion. There are some trabeculae inside, but they are thin. So it's just normal thinning of the trabeculae. Again, in this image, you can see the trabeculae crossing the lesion, confirming that it's a pseudocyst due to normal thinning of the trabeculae of the bone. When you do a CT scan, you can see that this area has thinned trabeculae, but it's normal. There is no lesion here. Everything is in place. No defect, no abnormality. Look carefully here. There is nothing. So this is normal thinning of the trabeculae causing pseudocyst. Now let's go to the uncommon and the more interesting pathologies of lucent bone lesion in the calcaneus. First of all, aneurysmal bone cyst. It has typical imaging criteria. We can see it in the MRI. Aneurysmal bone cyst on an X-ray has this typical characteristic bubbly appearance. It's like soap bubble. It has multiple areas of cystic changes. Okay, and when you do an MRI for it, it has very typical multi-cystic appearance with characteristic blood fluid level here and there, multiple blood fluid levels. This feature is very typical of an aneurysmal bone cyst, or what's called an ABC. Again, another example, on an X-ray, you have a multi-loculated lesion containing multiple foci of cystic changes, bubbly appearance, and you do an MRI for it, and again, it has a typical multiple fluid levels or blood fluid levels, call it whatever you like, it really doesn't matter, consistent with an aneurysmal bone cyst. Another very uncommon lesion to be seen in the calcaneus is a brown tumor of hyperparathyroidism. Brown tumor of hyperparathyroidism, it presents as a lucent bony lesion. There's nothing specific about it. You have to be aware of the possibility of hyperparathyroidism by taking clinical history, by seeing increased parathyroid hormone on the lab test, and when you do an MRI, you can see there is a lesion that is hyper and hypo intense on T2 weighted images. It's mostly iso intense to muscle on T1 weighted images. It's involving the calcaneus, well defined, expansile, and it's biopsy shown that it's a brown tumor. If you have a proper clinical history, if you have lab tests showing increased parathyroid hormone, it will be very typical for hyperparathyroidism. The other possible differential diagnosis is chondroblastoma, or what's known as Codman tumor. Chondroblastoma, it's just like chondroblastoma anywhere in the body, and it has nothing very specific about it. You can see it's a lucent bony lesion, well defined, and usually not destructive. And you do a CT scan, you can see that the chondroblastoma here, it's very well defined. It has no signs of cortical destruction. It has a narrow zone of transition. It's a benign lucent lesion. Okay, another example here on this X-ray and CT scan. There is a lucent bone lesion, very well defined, little bit expansile. What is interesting in this case is there's this thing here, which is the same as this thing here and there and there and here. What's that? It's pathologic fracture. The bone is weakened by the tumor, and now there is a fracture caused by the presence of this chondroblastoma. On an MRI, chondroblastoma has a very typical chondroid type of signal intensity, multiple hyperintense T2 foci within the lesion, suggesting a chondroid matrix. Again, on this MRI, you can see here, it has a very typical, this multiloculated iso-intense on T1, hyperintense on T2, and on post-contrast images, you can see the enhancement is mainly peripheral on the outer surface and the septi of the lesion of chondroblastoma. Very uncommon lesion to be seen in the calcaneus is a chondromyxoid fibroma. It definitely has nothing specific about it. You can see here, it's just a lucent bone lesion. It has some matrix, but you cannot say that this is a chondromyxoid fibroma. It's just a part of a differential diagnosis. Another example of chondromyxoid fibroma on the CT scan, you can see here, it's basically you cannot differentiate that from chondroblastoma. It's the same, or even a simple bone cyst, an aneurysmal bone cyst. Probably this is a little bit more irregular, but the differentiation is not that easy. On an MRI, it has a hyperintense signal intensity. On T2 weighted images, some irregular borders and irregular outlines. It has clear surrounding bone marrow. There is no bone surrounding bone marrow edema, no extension to the surrounding soft tissues, no signs of inflammation. So this was a chondromyxoid fibroma. Inchondroma is a very common lesion in the hand and feet. However, it usually is located in the metacarpals and metatarsals and in the phalanges. In the calcaneus, it's a very uncommon location for an inchondroma. So this was an inchondroma in the calcaneus. You can see it's just a lucent bony lesion, and it's very uncommon to see inchondroma in the calcaneus. For example, in this condition, there is a large lesion that's a little bit hypodense or lucent, and it's well defined, little bit expansile involving the calcaneus, and it was a large inchondroma, which is a very uncommon pathology to be seen in the calcaneus. Also, whenever we say aneurysmal bone cyst, we say giant cell tumor. In fact, both of them they show very common radiological appearances, and giant cell tumor is one of the tumors that tend to develop aneurysmal bone cyst within it. So whenever you see giant cell tumor, you mention aneurysmal bone cyst also. You can see in the X-ray it has a very characteristic appearance similar to aneurysmal bone cyst. It has multiloculated bubbly appearance on the X-ray, and on the MRI you can see in this case it's a giant cell tumor that developed an aneurysmal bone cyst within it, and you can see the multiple fluid or blood fluid levels inside. So whenever we see giant cell tumor, we should be careful that an aneurysmal bone cyst can develop within a giant cell tumor. Hemophilic pseudotumor is an uncommon appearance that affect the calcaneus. First of all, the patient should be a hemophiliac, and as a hemophiliac must be a male. You don't see hemophilia in females. So what will happen? Repeated episodes of bleeding resulting in what's called hemophilic pseudotumor. All the bone is changed shape. It's remodeled, and there are multiple hypodense lesions within the bone in a patient with non-hemophilia consistent with hemophiliac pseudotumor. Metastases can be seen anywhere in the body. Some places are common, some places are rare. So in the calcaneus, we cannot say there is no metastasis. However, they are uncommon. And if they are hypodense, of course, they are osteolytic metastasis. For example, this is a case of renal cell carcinoma with metastasis to multiple bones of the foot, especially the calcaneus is osteolytic. It's completely destroyed. Also, even the talus here and multiple bones in the metatarsals and tarsal bones. This was from renal cell carcinoma. On an MRI, you can see the entire calcaneus is destroyed, and this area here, maybe on other slices, we'll see other metastases here and there. And multiple myeloma also can happen in the calcaneus. If it's solitary, it's plasmacytoma. If it's multiple myeloma. We said that in a previous episode of Highlights in Radiology, and it has nothing distinguishing about it, just a lytic lesion with some cortical thinning and some trabeculae going here and there in a patient with an increased Benz-Jones protein and an M-band or electrophoresis. If it's solitary, it's plasmacytoma. If it's multiple myeloma. You can see here, for example, there is a big lesion in the calcaneus. In addition, all these bones are abnormal. There are multiple ill-defined lytic areas in this patient with confirmed multiple myeloma. Another example of multiple myeloma, you can see this is a big lytic lesion, again one here and one here and one here. There are multiple lesions affecting the tarsal and metatarsal bones in a patient with non-multiple myeloma consistent with myelomatous lesions. Another uncommon lesion to be seen in the calcaneus is sarcoma, like Ewing sarcoma, chondrosarcoma, any kind of sarcoma, rare, but it happens. So you can see here the bone is distracted, everything else surrounding it, just not like the metastasis or the myeloma. The rest of the bones are relatively normal, intact. I can't see any pathology there. We can see only this lytic lesion, cortical destruction here, and possible soft tissue extension. So what happens if we do another modality? You can see there is a lesion completely destroying the calcaneus, extending to the surrounding soft tissues, eroding the bone with surrounding edema, and biopsy revealed that this was an Ewing sarcoma. You can suspect that just by noticing the growth plate is not fully closed yet. So this is a teenager patient, and Ewing sarcoma is a very possible finding. Another case of Ewing sarcoma, you can see the entire calcaneus is eaten, destroyed, and even some soft tissue extension is available. This was all for today. Don't forget to subscribe and share. Please, any suggestions, any comments, write in the comment section. Don't forget to watch us next week at 5 p.m. on Friday. I am Dr. Ahmed D. Abdulwahab, and this is Highlights in Radiology. Thank you. Bye-bye.